Now I call upon Dr. Vijaya Pai for her talk on alpha agonists.
Good evening. At the outset, I would like to thank KSOS and the Drishti organizers for giving this opportunity. Alpha agonists can be classified into non-selective and alpha-2 selective. And now it's mostly, I'll be concentrating on brimonidine, which belongs to the alpha-2 selective. So these are no financial interest, but these are the variable concentration of brimonidine available, 0.2 to 0.15, 0.1. The lower the concentration, lesser the chance of allergic reaction. So what is the mode of action? So the alpha-1 stimulation causes vasoconstriction, resulting in restricted blood flow to the ciliary muscle, thereby reducing the aqueous production. Whereas alpha-2 also, there is a constriction of the post-junction, the vascular post-junctional alpha-2 receptor action causes vasoconstriction in the ciliary body and the episcleral vessels. So there is a reduction in the production. And also stimulation of the post-junctional epithelial alpha-2 receptor and decreases the intracellular cyclic AMP and decreases the production of aqueous and increase the uveoscleral outflow. Brimonidine also has increases the outflow. It's mainly by its action on matrix metalloproteinases and tissue inhibitors of the metalloproteinases. And these stimulation of this will cause degradation of the extracellular matrix, thereby increasing the outflow of the aqueous. Another mechanism, the brimonidine is favored because of a neuroprotection. It preserves the retinal ganglion cells by blocking the NMDA receptors, and it also causes upregulation of the endogenous brain-derived neurotrophic factors expression in the retinal ganglion cell, and BDNF is the one which promotes the survival of the RGCs, retinal ganglion cell, in optic nerve crush injury. And one study by Sai and Chang, it showed that patients treated with brimonidine appear to have less retinal nerve fiber loss compared to the patients treated with timolol over 12-month period. So the neuroprotection action, its application in clinical practice is difficult, though brimonidine meets all the criteria for the neuroprotection. But there are studies which indirectly prove the neuroprotection action of the brimonidine. One is that one of the study by Ruiz and Laputin et al. Showed that it may improve the mean sensitivity in the visual field. Another one was improvement in the contrast sensitivity as published in BJO by Evans et al. Another one was the article published by Ferenczi et al. Where brimonidine increased the survival of the neighboring ganglion cells. It reduced the laser-induced damage in patients treated for extrafoveal, the choroidal neovascular membrane. However, its application in clinical practice is limited because it may be because of that the animal studies cannot be extrapolated to the human application. So the indication, it's mainly considered as a second line or the third line drug. Combination preparations work very well, and the preservative in this preparation matters a lot because brimonidine is known to cause allergic reaction. So the purate form of brimonidine is preferred over those with the benzalkonium chloride as a preservative. And with beta blocker, it has the added benefit of neuroprotection. And brimonidine is the only one antiglaucoma drug which comes under the category B during the pregnancy. So during the first trimester, if at all a person has to be on medication, brimonidine is preferred. So what are the contraindications? As we know that earlier when we were doing postgraduate epinephrine were available, but those cannot be used with Nora angle. But alpha-2 selective, they have an additive effect with the oral MAO drugs because it causes sedation. And in children less than 2 years, it crosses the blood-brain barrier and causes serious side effect. And it should be avoided in children. They say less than 6 years, better to avoid brimonidine. Lactating mother, again, contraindicated because it's secreted in the breast milk, can have side effects in the children. So the side effects most common is the follicular conjunctivitis, reactive hyperemia, tachycardia, arrhythmias, and arterial hypertension. And specific for brimonidine is the iridocyclitis. So the iridocyclitis presents with the mutton fat keratic precipitates, but the peculiarity is that there are no posterior synechiae. And this iridocyclitis responds on stopping the brimonidine. And as I told you, the brimonidine lesser concentration has less allergic reactions, so preferably better to use 0.15% of brimonidine. So brimonidine in children, better be careful because it causes bradycardia, causes the blood-brain barrier, and causes sedation. So combined use of brimonidine and timolol can cause sudden decrease in the heart rate, lower the blood pressure, and even cause death. So better to avoid brimonidine in less than 6 years. Interactions, as I told you, it has an additive effect with the CNS depressants. Avoid patients who are on tricyclic antidepressants. And elderly patients also, we had to caution them that there is a risk of sedation. So driving, they have to be very cautious if they are using brimonidine. So in children, compared to brimonidine, apraclonidine is the safer drug. So take-home message is, it's usually a second or third line drug. As a combination with beta blocker, very effective in decreasing the intraocular pressure, and avoid in children less than 6 years. Thank you.
Thank you, Dr. Vijaya. That was a very concise presentation.